ALL is the most common childhood malignancy, and the most common type of ALL is B-ALL. And for many years, the genomics of B-ALL have really driven therapy in many ways. One, as far as risk stratification and knowing patients who had high risk, more likely to relapse, and giving them more chemotherapy, and those who were low risk and giving them less therapy, and then also some targetable lesions that we use new therapies for. In TLL, we've been very behind on that, and we really have not done a great job with genomic characterization. And part of that is, unlike B-ALL, a lot of the genomic alterations in TLL are non-coding parts of the genome. So for this large project that was very collaborative in the Children's Oncology Group working at St. Jude, we did whole genome sequencing, whole exome sequencing, and whole transcriptome sequencing of tumor and whole genome sequencing of germline from over 1,300 children of TLL. And through that, we were able to identify the genetic driver for the majority of children of TALL. Over half of them were in non-coding parts of the genome, and many of them were novel. We are currently in the process of integrating all of that genetic data with outcome, where the hope would be that some of these genetic subtypes will now allow us in TLL, it was been done in BLL for years, which is to identify patients that are more likely to relapse when they first present, and then treat them with different therapies at the beginning, or for patients who have very favorable risks, to actually treat them with less intensive therapy. The one thing that makes it a little bit more difficult is we did have to do whole genome sequencing to actually identify a lot of these lesions, and that is still very difficult to do at a large scale in the clinic.